Oh, Brittany.
Hey, Professor.
All right, so next topic is TB. We are on page 605. What is TB? Jen Park.
It is one of the most common bacterial infections worldwide.
Okay, very good. How do we get it?
The organism is transmitted via aerosolization.
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 Or airborne.
When a person with an active TB coughs, laughs, sneezes, whistled, or sings, infected respiratory droplets become airborne and may be inhaled by others.
All right, so it's highly communicable because of its size. It's less than 5 microns in diameter. So therefore, it's aerosolized. So anything smaller than 5 microns, that's why we need the N95 mask to prevent transmission, because they're that small. They're small enough to be carried in the air. Unlike other microorganisms which are bigger than 5 microns, so they typically only fall to the floor when you cough, sneeze. So that's why other bigger ones are droplets. Another thing to bear in mind about TB is it's a very slow growing bacterium. Meaning if you get exposed today, you will develop the disorder much later. Plus, most of the people who get it, only about 10% are infected. As shown here on figure 31.2. So about 10% will develop active TB. So the rest of the population, about 90 to 95, will have what we call latent TB, meaning an inactive form of the disorder. All right. So when exposed to the infection, again, you can either become infected or you become asymptomatic. But regardless, you were exposed to the bacterium. Okay, so again, I was on the same train with a person with TB, or I was a nurse taking care of this patient before we found out he had TB. Okay, because it's aerosolized, it's airborne. I merely have to be in the same room with this patient in order to get exposed to it. So it's the same way as you get chickenpox or measles. Okay, so same mechanism. It's airborne. As already mentioned, only 10% go on to develop active TB. So the rest of us, including me, actually, I had the latent form. Okay, meaning I had TB, but I did not develop the disease. But that doesn't change the fact that I was exposed. Okay, so my form was called latent TB or inactive TB. Secondary TB is simply the reactivation of a previous infection, meaning, let's say you had initial infection, right? And then you were symptomatic. And then later on, you develop, let's say, you acquired HIV and then you developed AIDS. So you can have a secondary TB as a result. We are increasing now in number because of migration, air travel made, and we're now more connected. So with increasing migration between countries, so it's now spread worldwide. But who are at risk for TB? Thank you for reading these, Mr. Tejindra.
Those in constant frequent contact with an untreated person, those who have reduced immunity, or HIV, adults who live in crowded areas such as long-term care facilities, prisons, homeless shelters, and mental health facilities, older homeless adults, abusers of injection drugs or alcohol, lower socioeconomic groups, and foreign immigrants.
All right. Most of these are self-explanatory. You can contract TB easily if you have these risk factors. For homeless adults, we specify only for older, because being homeless doesn't necessarily automatically put you at risk. But if you're an older homeless person, then that increases your risk. The abusers of IV drugs or those alcoholics, it's not really. It doesn't mean it's bloodborne. It remains airborne transmission, only because well, the reason why this is included is, I mean, if you're an alcoholic or an IV drug user, do you make the best judgment when you're under the influence? Probably not, right? I mean, you hang out in areas or with people that you shouldn't be around. So that's technically how you get exposed, how your risk rises. And of course, lower socioeconomic groups, that means your environment is also most likely in a crowded area. And then foreign immigrants. These are specifically from Asia, so that will include China, Philippines, um, most other Southeast Asian countries, Vietnam, and then also in Latin America, South America, or the Caribbean. How do we know you have TB? Thank you for reading this, Jenna.
TB should be considered for any patient with a persistent cough or other symptoms of TB, such as an unintended weight loss, anorexia, night sweats, hemoptysis. How do you say that word?
Hemoptysis.
Hemoptysis, shortness of breath, fever, or chills.
Okay, very good. And that is repeated again right here under physical signs and symptoms. History. Who has heard of BCG? Or that is Bacille Calmette Guerin vaccine.
All of us.
Okay, very good. So
West Indians.
all right, so most people who are born here probably never heard of this vaccine, because it's not routinely given in advanced countries. The risk of transmission is still much lower here, so they're not given to newborns here. In foreign countries, wherein mostly third world countries, wherein it's endemic in those countries, including mine, we have a high chance of contracting it. So all our newborns, pretty much around 30 days, in the first month, the child will be given a BCG vaccine. However, this is more effective with children or infants, protecting them during their most vulnerable years. But evidence has shown this doesn't provide lifetime immunity. There's also low evidence that this will protect most adults. Although you can give this to somebody, so let's say you're born here and you're going to an assignment. You have an assignment wherein you have a large population of TB patients. So you may be given a BCG vaccine, but again, it's not 100% guarantee that you will get it. Also, another common misconception is that if you received a BCG vaccine, that you will always test positive with a PPD. That again is no longer true. Evidence have shown that, again, the BCG vaccine does not apparently provide lifetime immunity. And if you look at fact sheets from the CDC, they clearly tell you that that's not always true. That although it can result in a false positive, that is never a 100% guarantee that you were not exposed to TB. However, we do have other tests to rule out that possibility. So let's say you did receive a BCG, and then you turned up positive for PPD, and then let's say you're not convinced. Oh, it must be the BCG. There are two IGRAs or interferon-based tests. Namely, you've heard of quantiferon, right?
Yes.
Yeah.
Okay, so quantiferon and another test called TB spot test. Somewhere here. Well, I can't find it. So quantiferon, this test is not influenced by BCG because this is based on um, a interferon assay test, meaning even if you had BCG, if you turn up positive here, this will rule out, meaning this test is not influenced by whether or not the patient received BCG. Okay. The only way we can confirm a diagnosis of active TB is, of course, only a sputum culture. Again, there are two forms of TB. So we have initial infection, right? And then we have a secondary TB. For initial infection, again, you can either have become symptomatic, wherein you have the signs and symptoms of the cough, the blood in the sputum, weight loss, fever, chills, night sweats, or you can be asymptomatic for the longest time. So it could be years or decades before you even turn up positive. But regardless, you had the initial infection. It's just a matter of whether you belong in this 10% here or you belong in this 90% here. Are we clear with this so far?
Yes.
Okay. So for the symptomatic patient who has active TB, the only way really we can confirm that is to get a sputum culture. And if that grows TB, then it's positive. If you have no symptoms, and then you turn the positive from either a PPD, the quantiferon here, or here's the T-spot TB test. None of these tests confirm you have TB. All these tests, the PPD, the quantiferon gold, T-spot TB, all just say that you've been exposed to the TB bacillus, not that whether or not you have active disease or you have latent disease. Are we clear?
Yes.
Okay, so it clearly tells you here a positive result on any of these tests. It just tells you that you are infected. The infection again would either mean you have active
Latent
or
or active.
latent TB. These tests here, the PPD, the quantiferon, none of these will confirm that. Only a sputum culture. But again, sputum culture will only be taken if you have symptoms. So if you don't have symptoms and you're positive on any of these tests, then we can confirm that with an X-ray. But even an X-ray will not tell you whether or not you have an active or a latent disease. Okay, so we have to take an X-ray to see also if is this a new infection or is this an old one? Because it's also possible that you may have had TB long time ago, and the lesions you see are old rather than new. Since PPD is still being used, although the most convenient test now is the quantiferon gold, we still use PPD widely, especially in the long-term care facility. In fact, they have the two-step. I think you guys also received the two-step, right?
No.
Those of you who had PPD?
Yeah, I did
Two-step
have
of
two-step.
quantiferin.
I did
Okay,
a
so most of
quantiferon
you are
too.
on quantiferon already. All right, let's go to the interpretation. Okay, quantiferon, no problem. Hi, good night. Quantiferon gold, we will only
Good
do-
night.
what?
That was so cute.
Okay.
Sorry. Okay, I'm
Oh, my
sorry.
camera is on. Okay, sorry. So when we read the PPD, they are read twice. So one at 48 and then another at 72 hours, correct? Again, our result is based on induration, not the area of redness. So the induration is the raised area as shown here. So it's not the redness, it's the whether or not this area is raised or not. So if it's raised by certain millimeters, then we will determine whether or not it's positive. So I'll turn you back again to the CDC, one of the links I sent you. All right. If you look at the handouts, these are all fact sheets from the CDC. We have three groups of people. So three groups of patients. So if your patient belongs in this column right here, these are all immunocompromised patients. If your patient has any of these profile, then the PPD test is considered positive if the induration is 5 or more. It doesn't take much because remember these patients have a weakened immune system, so therefore their inflammatory response is suppressed. So we can't expect a large reaction here. So a 5 millimeter induration is already considered positive in this population right here. If you belong here, so you're either a recent immigrant, that recent immigration must be within the less than 5 years from the countries I mentioned earlier. If you're an IV drug user, or you're a resident or an employee of a high-risk congregate setting, namely the nursing home, the prison, psych mental health facility, hospitals, okay, all those. And you work in the or you work in the lab wherein you handle the specimens, including the sputum specimens. Persons with clinical conditions that put them at risk, this would be sickle cell patients. I remember what we had in pneumonia earlier. The same people who have certain conditions like cancer, for instance, and then children less than 4 years of age, and family, including children who are whose family members are working in those high-risk conditions here, high-risk congregate settings. So for them, it's already considered positive if they have an induration of 10 or more. For the general population who neither are in column 1 or are not in column 2, the general population will require an induration of 15. Any questions so far? So on a test question, you'll be given the patient's profile. So the scenario will begin with, who is this patient? What is their history? What do they do for a living? And then I'll give you the PPD result. And then you'll either decide that the question will ask you either what will you do, or what it's asking you to interpret the reading, or it could be a teaching. All right, so that would be the question. So for you guys, are you 5s, 10s, or 15s?
We're 15.
15.
And if you work in a hospital.
10.
You wish you were 15. Before you went to nursing school, you were 15. But
Oh, yeah.
since you're now going to clinical, are you now exposed to those high-risk congregate settings?
Yes.
Yeah,
You
10.
went to a nursing home, although you technically didn't work or live there, but you were exposed there. You spent hours there for so how many weeks? And before all this started, some of you did go to the hospital, correct?
Yeah.
All right. So you're no longer 15. Okay, you're not virgins anymore. So you are now 10. All right, let's proceed. So that's for PPD interpretation. And please read the rest here about who needs to be screened. So of course, any one of us here, because we're healthcare workers, we need annual screening. For me, for example, because I already know I'm positive because I had latent TB, I've been treated for it. So therefore, all I'll submit them is just proof that I'm still negative. Okay, but I won't be required to submit the PPD because of course it will be positive. So I'll just submit an X-ray proving that my lungs are still clear, TB free. For oh yeah, it will just vary what my employer will require, whether they want it every year or every 2 years.
Professor,
Yes, boss.
is it going to be the same, basically like rules and I guess like therapeutic management as in peds? So if a peds case has like TB, is it going to be almost the same exact practice that you do for peds and adults?
Are you talking about testing or treatment?
Both.
Oh, both. I'm not sure about the treatment. Okay, as far as dosing, I will leave that for pediatrics. That would be a perfect question to ask Miss Buckner.
Yeah, but besides for like the dosing, like the 9-month regimen of the
yeah, that's exactly what I'm
medication.
referring to. I don't want to answer that because I don't know what the duration and the dosing is for pediatrics.
Okay, thank you.
Okay. Interventions. The only intervention is because this is a highly contagious organism, so and a very slow growing organism at that. So the patient needs to be treated with antibiotics. And because it's slow growing, we want to make sure we get it. And that's why also the therapy is quite long. We're talking about minimum 26 weeks here. Oh, so that's at least 6.5 months. Because again, the nature of the organism, it's very slow growing. So it's harder to treat. So you need to make sure our treatment is really aggressive. So combination drug therapy remains well, depends really if it's latent or active TB. For latent, usually you get two drugs therapy for about 6 months, which is what I got. But really the doctor decides on what he'll give you. So for our purpose for the exam, we will do regimen, oops, wrong. We will do the third link I sent you. Okay, so this is now the treatment. Can you see my screen?
No.
No, we see you.
Okay, let me see. Okay, it's telling me
INH,
again,
the RF, EMB, and the PCA. That's
yes, share screen. Should be this screen. Okay, here. Can you see this now?
Yes.
For TB disease. Okay, so look at only the first regimen. There will be so it's regimen 1, this one. So if you expand this one, TB regimens for drug susceptible TB, we'll test regimen 1. Okay, this one right here. This is also mentioned in your textbook, but in the paragraph, it's not very clear. So I prefer to explain it using this table right here. So again, regimen 1, who gets regimen 1? Thank you for reading, Miss Dulligan.
This is the preferred regimen for patients with newly diagnosed pulmonary TB.
Okay, which is our most common patients. Okay, so this is a 4-drug regimen, but look at how it is, because is it easy or hard to take something for a long time? Not to
Hard.
mention the restrictions. Yeah, plus look at the profile. Who are these patients again that get TB? Are these like you and me usually? I mean, active TB. Who
Nope.
are those at risk again? What is the picture?
IV drug abusers.
Exactly, right? So
Homeless.
homeless, older homeless people. Okay, so are they your typical patients that are compliant?
New.
No. All right, so it's important to explain it to them. Of course, you'll have resistance, okay, especially when you get to the restrictions, like you can't drink alcohol, and then they'll say, of course, what did you say? I can't drink alcohol? Okay, no, I'm not taking that. So explain to them that, okay, so the 4-drug regimen really is during the intensive phase. And if you look at the intensive phase, it's actually how long? 8 weeks. So for 8 weeks, the patient gets 4 drugs. After that, this is the intensive phase. The continuation phase, you're down to 2 drugs. You're only down to INH and rifampin for another how long? Another 18 weeks. Again, it's 26 weeks, so that's 8 plus 18, 26, so that's about 6.5 months, but it's not that bad. Relatively, it's relatively okay, because the 4 drugs will only be taken for 8 weeks, and then after the 8 weeks, you're down to 2. All right? Okay, let me go back. You have questions?
No.
Okay, go back to the textbook. So your drug therapy, which is now your testable part here, of course, the regimen, you have to know how to give it, because you have to explain this to your clients. Chart 31.3 are now the specifics about safety, making sure they remain safe while taking these for at least 26 weeks. Because it can extend if, let's say, what grows on the sputum is a drug resistant type. So this will be longer, okay? But the minimum is about 26 weeks. But again, it could be longer depending on the strain that you have. So INH, these are your teachings for the patient. Please do not confuse darkening of the urine with orange reddish color of the urine and other body fluids. Okay, this is different. When you say darkening of the urine, that means this is now bilirubin inside your urine. This is, of course, evidence of liver toxicity. Okay, so again, darkening of the urine, which is you're supposed to tell the patient to report. This one is not reported, because this says here, you expect a reddish orange color of your body fluids, not just your urine, but tears also, and even your skin. Is that clear?
Yes.
Okay.
Yes.
But almost all of them, you need to avoid drinking alcohol, so that it tells you that the drug is very hepatotoxic. And this drug, also another detail is you take B vitamins with them, because that will deplete your supply while taking that drug. And this drug also tells you, well, this is a given. You're not supposed to take any drug with antacids anyway. But this one, you take it with an empty stomach. So please read the details. Questions. So there will be a question on each drug. And this one interacts with oral contraceptives, so take note of that. So that's for Refam. Then for PZA, this one causes uric acid buildup, so you're supposed to drink a lot of water while taking that tablet. And then ethambutol, this one causes optic neuritis. And there's a little bit of difference here. For ethambutol, it doesn't say it's hepatotoxic. All it says here, though, is that you don't drink alcohol because it causes or induces severe nausea vomiting. But since you're taking all 4 drugs anyway, so you can't drink alcohol with it just the same. Although this does say, I mean, it doesn't damage the liver, but it does cause severe nausea vomiting when taken with alcohol. Okay, since most of them you have to take them, and then most of them cause liver toxicity anyway, so alcohol is a no-no. So it wasn't easy either. So you go through holidays. I went through, my birthday, my wife's birthday while on it. I mean, you can't believe how much sacrifice that was, and no alcohol for 6 months. So
We feel
because
sorry for you, Professor. Sorry.
I know, yeah, it was the saddest moment in my life. These patients, okay, I have 2 minutes left. For patients, of course, you got these homeless people, and some of them are veterans, right? So if they start saying, "Oh, I thought this is America, right? I thought it was America. I don't have to take that drug." Okay, and then they refuse. Can they do that?
No.
Yes.
Well, they could say that, but they really
What
can't.
accent
Won't
was that,
go anywhere.
Professor?
I don't know.
Your
So
accent
the
left.
point is, it's a very communicable disorder. You don't want these people riding the subway or exposing other people to the disease, right? So if they, of course, we won't threaten them. We just talk to them, as best we can. That it is very dangerous, or you have to take these. They'll be put under direct observed therapy. This was originally developed in the third world countries, wherein they take their medications and swallow them in front of a caregiver, to make them more compliant. We give them everything they need. So we'll give them, metro cards, meal allowance, just so they take it. Okay? Again, the success of the treatment depends on their compliance with the drug. I still need a few details, so I'll just start this after the break. I'll see you back at 10 after.
Okay.